weekly IDMP seminar series at the Broad Institute. As you all know, we're doing a special series that's relevant to the current COVID-19 pandemic. So thanks so much for joining. Today we have a special speaker, which is Paul Farmer, who requires a very little introduction to most. Paul is best known for being one of the original founders of Partners in Health, which defied the odds and defied the world in bringing HIV care to the rest of the world. And currently he is the chair and professor of the Department of Global Health and Social Medicine at Harvard Medical School and the Brigham and Women's Hospital. So a little bit of background, personal background on Paul. So I knew Paul way back when I was a medical student. And I remember we would have arguments about bringing HIV care to the rest of the world. And I was one of those young, naive skeptics and was thrilled when he proved me how wrong I was. Then I became an ID fellow, and Paul was infamous among the fellows when because he was attending, who you knew if you had policy attending, you would be rounding in the hospital till midnight. Not because you had so many patients, but because Paul knew everybody and everybody knew Paul. So you had to make sure that you stopped and talked to everybody as you made your way through the halls of the hospital. And that's Paul, right? Everybody knows him and everybody loves him. And so that's why I asked him to come and give his perspective on the COVID-19 pandemic, particularly given his experience in places that are more unfamiliar to us, and those are resource-limited areas of the world. Paul is used to speaking to standing room crowds, and so this will be the virtual standing room crowd that he'll be speaking to today. I should say, if you have questions, please make sure that you type them in the Q&A function of Zoom rather than the chat, so we can make sure we capture them, and we will leave plenty of time for questions at the end. So Paul, take it away.
Thank you, Deb. And I guess it's never late to apologize for keeping you late at the Brigham, but then you seem to like it there, so as we all do. I thought I would just kick things off with just a couple of brief comments about the Ebola epidemic that began probably late in 2013, because I was and am involved in it, and because it sets the stage for the discussion that we can have about Ebola, coronavirus, COVID-19 management in resource poor settings. Does that sound okay, Deb? Let's see. I'm just trying to advance the slides real quick. 1 second. It's all good. Just some background about these particular pathogens. The filoviruses, Marburg and Ebola, and you know, the stories are interesting. The stories of the people are interesting, but the stories of the people who discovered the pathogen and how it came to be are interesting too. And they tell us a lot about the world, just as we are learning now with a novel coronavirus. As far as Marburg, and that's the top image, the top is Marburg, the second is a famous image of the Ebola virus, the third is HIV. Viruses that have zoonotic origins, that is an animal species, can make a jump into the human population. And they tend to cause serious disease. In fact, the immune system, and Deb knows more about this than I do, but the immune system of the human has evolved largely in response to infectious pathogens, with viruses at the top of the list. So Marburg, how did that come? If it's an African virus, then why does it have a German name? And it's one of those stories of the international political economy. It was actually from green monkeys, probably from Uganda, shipped to Europe, not for research, but for the production of polio vaccine in the 60s. And on one trajectory from somewhere on the continent of Africa through London into Marburg, then Hamburg, then Belgrade, came these monkeys sickened by the virus, exposed to humans, largely lab workers first. And then when it burst into the human population in Germany, there was a sudden onset of a very critical illness with a lot of GI features and sometimes at the end hemorrhagic signs. And this was named after the city in which it was first identified, which was Marburg, Germany. It required electron microscopy, which of course was unavailable in places where there are no labs, no electricity, to say nothing of labs. So I'm going to talk today about the clinical desert, which is not a place like Marburg, but a place like Yambuku, Zaire, which was a mission station in the northeast of then Zaire, a Belgian, recently independent country that had been a Belgian colony. And there was a mission hospital, and there we have to use quotation marks because this was a hospital with 100 or so beds, but no physicians on staff. The hospital was run by a group of nuns who had become nursing sisters and people from that part of Zaire. And there was an explosive outbreak of a lethal illness, lethal fatal illness, which presented with fever, fatigue, and a lot of GI symptoms. Actually, if you look back on the descriptions from the initial outbreak. Anyway, it was an unknown pathogen. Again, those samples had to make their way to labs where a new pathogen could be diagnosed. In this case, they were shipped north from Kinshasa to a number of labs, including one in France, one in England, and the CDC. And it was known that this explosive outbreak was killing 80, and it proved to be even higher, 80% of the people involved. So again, you have this strange juxtaposition of Europe and Africa, or the United States and Africa, whether because it's a clinical desert, these outbreaks are not recognized when they're occurring all the time. And in these two instances, Europeans were involved in the way in the path of discovery in one way or the other, as patients, or as caregivers, or as researchers. And then I mentioned the Sudan. And by the way, if I could go back to Marburg for a second, the Marburg outbreak and the European outbreak in general, which was largely confined to those three cities. One of the things that we learned in 1967 in the Marburg, what later proved to be Marburg, was that the absence of a specific therapy, meaning an antiviral or a specific preventive like a vaccine, even in the absence of specific therapies, the non-specific therapies that we still use to this day and are using to care for COVID-19 patients, the non-specific therapies, IV, fluid resuscitation, oxygen when you need it, expert nursing care, food, or attention to one's nutritional status, that saved over 80% of the Europeans, even though this was a completely unknown pathogen. And in 1976, in Sudan, when a Marburg outbreak was identified, the case fatality rates were in Africa were more towards 100%. So that's the backstory of emerging infectious diseases, at least this family of them. And it's been going on that way, chugging on that way for decades. An explosive outbreak, maybe it'll be identified in the clinical desert as a new pathogen, maybe it won't, maybe it'll be identified as an old pathogen, maybe it won't. But it's very difficult to know what's going on without testing, and then very difficult to impossible to take care of people without the staff stuff, safe space, and systems required to do so. Sorry, can I just go advance one more? Is it? Oh, got it. And this is infectious disease doctors love to do this. I'm sure that Deb is not seeing a COVID patient and making a long differential diagnosis. But the point is, you have a fever, some GI symptoms, a cough, chest pain, fatigue. It could be anything, right? So the lab part is critical, and I imagine we're going to get to research, but the lab part is critical for the clinical identification and clinical care. Again, these are straightforward things. So I'm just, which one do I push for? Just the center of it. And then just to go on to this recent experience, and I'm going to just speak in first person. I only knew in the summer of 2014, I only knew 3 or 4 Sierra Leoneans. One was a student of mine, Byler Beria, who's looking rather stout there. One was a surgeon, Martin Salia, in the middle, and one, Humar Khan, who was scheduled to be at the Broad in 2014, 2015, working with Pardis Sabeti and others, was an expert on hemorrhagic fevers, particularly Lassa, which, along with colleagues at the Broad, he helped to sequence Lassa fever. Now, just by happenstance, I was organizing, along with others, a surgical conference. And the point of it was a Lancet commission looking at surgical care in resource-poor settings. And the first meeting we held it at Harvard Medical School, and the third one we held in Dubai. Not really a good message if you're trying to focus on surgery in resource-poor settings. So we said, let's have the second meeting somewhere in the clinical desert. And Sierra Leone, which had emerged not too long ago from a brutal civil war and had seen a different kind of surge, that is a surge of armed rebels, lay waste to the capital city, and the same had happened in the neighboring Liberia. That surge took out their healthcare system about a decade before Ebola would come along to trouble them. And in that summer, as people were still trying to get over the war and attend to building healthcare systems, this group came together. That was the plan. And just about a month before, the World Health Organization announced that no, the epidemic was not contained in this part of West Africa, which a lot of people call Upper West Africa. And I was in Rwanda at the time, and we were under some pressure to cancel the meeting or choose a safer venue. And we didn't, because we could tell that this was not a pathogen spread through medical conferences. It was spread through caregiving, because once the virus makes the leap from whatever the source is, be it a bat or some other animal that's tolerant or evidently more tolerant of these pathogens, when it makes the jump to humans, animals aren't part of the picture anymore. It's human to human transmission of the pathogen. And these people were all standing in harm's way, of course. And in between when we had the conference and left at the end of June, Humar Khan sickened, as did a very substantial fraction of the nursing staff of Kenema Hospital. And his friends and family wanted him to leave the country, get out of the clinical desert altogether, but that had never occurred by July 29th, which was when he died in an Ebola treatment unit further to the east. And I can spell this out in a map, but basically the epidemic was held to begin in the forested eastern segments of these 3 countries, the third one being Guinea. Liberia, Sierra Leone, and Guinea come together in a very narrow and still somewhat forested strip of land. And that's where the initial spillover event was held to occur. So at that time, in the late summer of 2014, that part of West Africa was facing the same challenge. Can a surge of cases in the urban areas to the west be prevented in order to save the healthcare system from complete collapse? And those were the terms of the debate. And I was involved in the debate, having known Humar Khan and also chivvying my colleagues at Partners in Health and in Rwanda and anywhere else who would listen, that we should go and respond to the outbreak. Now, the interventions of this very complex and large containment machinery were insufficient to stop the surge. And so within those weeks after Humar Khan's death, and before we arrived to actually do the work, tardily, I'm afraid, the virus continued to surge west toward the Atlantic coast and took out all of the healthcare system, everything. So that means that the hospitals and clinics across those three nations were all shuttered. And so were the schools, including medical and nursing schools. And there had been few of those. The British, in their long tenure in Sierra Leone, founded all of 0 medical schools and 0 nursing schools. So after 200 years of British rule, when they left, the Sierra Leoneans, for example, were scrambling to establish these institutions, and then came the war. So this is what a clinical desert can look like. We're not living in a clinical desert here, although the pressures on our caregivers is intense. It's a different situation. And if you look at so this was a caregiver's disease, and if you look up in the corner, you see that Newsweek cover from August. This is after Humar Khan dies, I think. And they're still talking about bushmeat, like don't eat bushmeat, be careful of monkeys. Meanwhile, this is all human to human spread, and it's spread by one thing: caring about other people, caregiving, right? So in the absence of professional caregivers, there are, who are the caregivers? They're your family and traditional healers. And these three patients, former patients, these young people have a very different story in some ways than the three physicians I presented, one of whom, my student by the Berry, never got ill, thankfully. But it's still a story of caregiving. So the young woman over on, who's looking, well, I guess they're all looking away from the camera. The young woman who's in a pink and gray blouse. So she was the mother of an infant. That's the father of baby in the middle, and that's her best friend. And the story was that her grandfather was a traditional healer to the north of the capital city, Freetown, which is again where the epidemic was headed during the surge. And he fell ill. His son, her father, came to take care of him. He came home to Freetown and he got sick, and then she started nursing him. Her best friend helped her, and her partner, Mohammed, was involved in caring for him too. And when he died, the father, Mohammed, helped to bury him. All three fell ill. The baby died. A number of people in their family networks died. And that's really how it spread. It spread through caregiving. And again, the last act of caregiving in many religious traditions, including this one, is to bury the dead. And that's a time when bodies are particularly infectious right around that time. And so there's a lot of transmission through that last act of caregiving as well. And just to, make these points that have been made again and again, and why we look at case fatality so often is, if you go back and do that exercise, just looking at case fatality, how many people died of Marburg in 1967 without even knowing what the pathogen was in Central Europe? That is Hamburg, Belgrade, and Marburg. And the answer is, like I said, close to 80% survived. Meanwhile, the same pathogen in the same species it jumped to, ours, was killing 80-90% of the Africans afflicted. And it was a similar experience in some ways during the course of the Western surge, as we're trying to say, hey, we need disease containment, but we have to have better care. We have to have better care. And again, this is, yes, we were looking for specific therapies. You remember the names of them. Some of them, they're still being talked about with coronavirus. But what we really needed was supportive and critical care. And for many listeners, those will be familiar terms, but I will just say supportive care is what you get from a nurse in an emergency room. That is fluid resuscitation if you're losing fluids, oxygen if you can't breathe, et cetera, et cetera. And then critical care is the term that we reserve for when you need mechanical ventilation, renal dialysis, et cetera. So these non-specific therapies are what we needed, and we didn't get it, so we didn't do it. We didn't make it happen. So when Deb introduced me so generously, and we were talking last night, but she was saying, well, you guys challenged the status quo before. What are we going to do now? I'll let her re-ask that question. But I feel that at the end of this long epidemic that went on for years and was taking out caregivers. And they ended up losing close to 1,000 doctors, nurses, lab workers, ambulance attendants, et cetera. And to me, that means that we failed to protect the caregivers and failed to prevent the surge. When people ask me, well, what stopped Ebola in West Africa? I sometimes think and occasionally say the Atlantic Ocean, because that's, it saturated the big cities, and that may have been new. So the other, and the last point, I'll go back to Deb. When people were airlifted, this is just inside a couple units, which shows the decline in case fatality rate, which is a good thing. Let's see. How do I? Just trying to do this last one. When you did look at data from European and American hospitals among people who were airlifted, it's really the first time you got a good look at their ins and outs, meaning we saw that this was a very heavily gastrointestinal disease. It wasn't around blood loss or hemorrhagic signs and symptoms in the great majority of patients, but about fluid and electrolyte losses, among other things. But again, these have to be measured as outs in order to be replaced as ins. And when we started doing that, we saw that it was indeed critical care, or at least aggressive supportive care, that was needed to save these patients' lives, and their lives were saved. And I thought that, Deb, I would stop there. Just saying that, and this was a discussion we had a month ago, when the Wuhan clinical data started to be available in English. For me, it was with an article looking at 138 cases of COVID-19 from Wuhan. It was published in the New England Journal of Medicine. It really showed that about a quarter of the patients needed some kind of aggressive supportive care and or critical care, maybe even a quarter of them. So that, back 2 months ago, was the cry of alarm that we would need more critical care beds, more vents, maybe field hospitals in this country and elsewhere, that the virus was likely to spread, which, as you all know, it's hard to know where it's not likely to spread. And that's kind of where I think we are today. And Deb, forgive me if my review of the Ebola experiences was too long, but
no,
I brought up some of the points that we talked about last night.
That was fantastic, Paul. So let me start with a few questions. You've lived through now HIV, Ebola, several outbreaks now. Where do you rank COVID-19 with regards to concern? Are you frightened? What is your perspective?
Well, I would rank it at the top of the threats I've seen in my life. I started medical school in 1984. So that was a time when HIV had recently been described as a syndrome, again, because it wasn't in the clinical desert, but in cities in the United States, it had been in the clinical desert. We don't know how many decades or how long community-based transmission of HIV had been going on, or when those initial jumps in the human populations may occur. But we discovered it and described it in affluent countries, so-called Western countries, United States, Europe, affluent parts of Asia. And it was during those years of the 80s, this was our hospitals, the Brigham, the Mass General, the Beth Israel, the Deaconess. These hospitals were full of young people dying of HIV. HIV was then the leading infectious killer of young adults, men and women. And we just didn't have the therapies. We knew how to prevent some of the cases, certainly mother to child transmission. That was in the 80s when that was discovered. But it really wasn't until the 1994-95 that the real power of suppressive, they were used to be called AIDS cocktails, hilariously, but 3 or sometimes 4 drug combinations of antivirals. That would not only save lives, it would clear out hospitals. So the end of my infectious disease training was much different from my training as a med student. And in those years since, back to your point, COVID-19 is, it seems to me, far and away the biggest challenge. And, you know, also Zika ripping through Latin America, that was tough to see those cases of Guillain-Barré and paralysis. Ebola was a nightmare, but it was concentrated in 3 countries, you know, all really damaged by or leveled by war in years preceding. And this, you know, is close enough to the big one that I have no problem, Deb, saying, yeah, I'm scared.
Can you give us a little bit of insight into what the thinking is in the different places that you're, you know, that you have contact with, that you're visiting, and you know, what kind of, you know, what is their perspective? What are their fears? What kind of preparation are they trying to put in place, and how that differs from efforts here?
Well, let me just talk a little bit, Deb, about 2 places, the ones I've been keeping closest touch with. Partners in Health, as an aside, works in 11 countries, but of course not each of us works in all of those places. So Haiti and Rwanda. Well, first to say something cheerful, which we still need to do. I was there last month, and at the end of January and into February. And I think what struck me was the serious, that's even a word in French, the serious, but the seriousness of Rwandan attempts to prepare. They brought some of the Partners in Health folks from West Africa, by the way. There was an Ebola epidemic on the eastern border at the time. It was just kind of finishing up. A number of our Brigham colleagues have worked there, but a number of our Partners in Health colleagues. So they had already been with heightened attention to Ebola on the eastern border, the western border of Rwanda, eastern Congo. And there was already this somewhat marshaled but calm sense that we will protect our borders, we'll have a plan for anyone who comes in with, in this case, Ebola. This is, you know, any febrile symptoms. And I know from my experience in West Africa, because we were living in Rwanda, and I was saying, I really want to come home. And the Minister of Health was really, at the time, really one of my closest friends. She's a pediatrician. She said, well, we have a lovely isolation unit for you at Kanombe Military Hospital. And I said, well, but I want to see my kids. And she said, then I threatened to complain to the head of state. And she said, go ahead, he's going to side with me, which was true. This was a serious effort even then. And over the years since then, that was 2014 to now, I haven't seen a great deal of relaxation in their preparedness exercises and drills. Yes, they lack staff, space, and systems, and that could be grievous for people who need mechanical ventilation, although they're preparing for that as well. But right now, I think the official number, I spoke to colleagues there yesterday, is 45 cases, you know, with social distancing as it can be done in this is one of the most crowded countries in the world, having been in place for 2 months. And again, some of the warnings from Wuhan and from Hubei province, it seems to me that the Rwandans took those much more seriously. Well, I should be very careful. It seems to me that the Rwandan government took that seriously at the highest levels, and perhaps more so than what we saw here in the preparations in those same months. And so I'm optimistic about the overall prospects for Rwanda to control the epidemic and to find new ways of providing care, whether it's in MASH units or which they're also already set up. That will be the challenge. They'll need staff, space, and systems just like anyone else. Now, Haiti, on the other hand, has more resources. They have, I mean, how did we start our programs in Rwanda, Malawi, Lesotho, Sierra Leone, and Liberia? We started with our Haitian colleagues. after decades of training Haitian physicians, nurses, lab techs, managers, we have a crackerjack team. Partners in Health in Haiti is called Zami La Santé, and they're amazing. And so they have in Haiti more human resources for health, and but they have more of the staff, but I'm not sure that I know they don't have enough systems or space rather, safe space, because managing coronavirus in a unit without respiratory precautions and contact precautions, which require space, meaning literal space around the patient, is a sure way to promote nosocomial spread. So, and then stuff. I mean, we just, the COVID test that we sent just arrived yesterday. And then the systems. That's where I think Haiti and many countries, including the United States, have been weak, right? There's not a national system-wide approach in the United States as we've seen, because there's a lot of role for local government. So we have this very patchwork response. Rwanda doesn't have that, and Haiti is trying not to have that, but they lack the staff, space, and systems. So that's where things stand. There are a number of coronaviruses in Haiti. Most of them are at some point, a substantial fraction of them have been from other countries, and they're being cared for. I happen to know something about the conditions of their care, but that's the situation right now. And one of the things that we're desperately trying to do is to not shut down the healthcare system, like we saw so traumatically in West Africa, and has occurred during those wars, and has occurred during the genocide in Rwanda, and as we have seen after the earthquake in Haiti. There's nothing worse than seeing a healthcare system flattened. Now, in the case of Haiti, it was literally flattened, right? But an empty hospital in the middle of a crisis, a health crisis, is a creepy thing to look at. And we've seen it too many times, and we're desperately trying to keep this network of hospitals and clinics open.
So I'm actually hearing a little bit of optimism from you, just as they say that some of the East Asian countries had their trial runs, right, with SARS back in 2002, 2003, with H1N1. I'm hearing that, Ebola and these kinds of things actually have prepared these countries probably even more than we are in the US.
Well, the argument may be made case by case, Deb. For example, Rwanda, which actually hasn't had Ebola outbreaks, but is right next to them, is well prepared, has used those events on the other side of the continent, to which they also contributed staff, by the way, and stuff. The Rwandan government sent staff and stuff to West Africa. But the social residue, the programmatic residue, the policy residue of the West African Ebola epidemic seemed to have more vigor or in Rwanda. Now, Sierra Leone and Liberia are in a pickle. Yeah, everybody knows about Ebola. They could tell you the signs and the symptoms. They can give you the hypotheses. They know it's a caregiver's disease. They're not perseverating about bat soup, they know. But having lost so many of their professional caregivers, right, and the traditional healers, having lost so many, all told, in people who consider themselves caregivers, that would be thousands, right? They don't have the staff, even when they do have the stuff, and even when they do have better space. I would like to say, though, that a lot of the units, the ETUs, the Ebola treatment units they're built as temporary structures. And in those conditions, with 200 inches of rainfall a year, they molder and disappear under the vines in a matter of months. So those spaces are not, I shouldn't say this without going to inspect myself, but I can tell you that the ETUs where I worked have really gone to seed, meaning they were always meant to be temporary structures. So I do want to have some optimism. The cognitive knowledge is there in those places. The experience is there, but their losses are so great that I'm very worried about Sierra Leone and Liberia, and to some extent, Guinea as well.
And then, of course, this is a very different virus, right? Where there's respiratory transmission,
Yeah.
And it's progressing so rapidly. How does that change your thinking? How does that change the thinking in the different countries you're in?
Well, I can't help but think about tuberculosis, of course, which is the number one infectious killer of adults in the world still, and also a respiratory pathogen. So all this talk about, how is it spread? We knew that it was spread through respiratory droplets from the beginning. It may be spread in other ways, but we knew that at the outset. SARS, looking back at those data, and I'm sure others on this call have done this better than I have, but looking back at the data, just on the geographical layout of units and how beds should be spaced, those data, those studies suggested that, you cough, you expel the droplets in the air, they fall to the ground, and who's in the way on the way down? How far can they be? A lot of this was, I'm not saying known well, but it's not as if there were no academic residue left from the SARS epidemic of 2002, 2003. So that's why this could be the big one. There are other pathogens that are far more infectious in terms of respiratory transmission. But the fact that this can be spread at all through respiratory droplets is really tough, especially if you're living in a refugee camp or a slum. Or just a crowded rural household, on a mountaintop in Rwanda. It's 5,000 feet above sea level where one of the hospitals is in Rwanda. People crowd into poorly ventilated homes. How do you do social distancing in settings like that? It's just the material impossibility, not so much in Rwanda perhaps, but again, you're thinking about refugee camps or prisons where people's agency are taken away. I think we have a real problem. We know we have a real problem on our hands, and I think it's just better to assume that this is a bigger problem than Ebola or Zika, maybe even HIV.
So I've thought many times back to a conversation you and I had several decades ago. At the time, you were arranging for a patient to be flown up from Haiti to the Brigham, a single patient to have heart surgery. And at the time, we had one of our usual very heated discussions about how one chooses to invest when one has limited resources. How should one think about that now in places like Haiti and Rwanda and Malawi when one has limited resources? There's this kind of tension, as you know, in the United States and in countries in the West where, we debate, should we be in, containment mode? Should we be in mitigation mode? How are we, should we be focusing on public health versus on, the individuals in clinical care? How are they thinking about it there? How should we be thinking about it there?
Well, that offers me a good chance just to say, again, we don't have to choose between containment and mitigation on the one hand and improving quality of care on the other. If you're at the Brigham right now, it's not to issue a quarantine order. You're taking care of patients. And we don't have to make that choice as societies, maybe as individuals, maybe as professional bodies, maybe as people dividing up responsibilities, of course, right? But collectively, for us to make a decision between containment and care is a mistake. And the American people won't tolerate it anyway. But I'm just saying that's how it feels everywhere. Like if Rwanda were to make a mistake and only focus on containment and mitigation and not on taking care of people who are sickened, they will have less mistrust in the general population. And that's what we saw in West Africa. They were unaccustomed to being cared for except by traditional healers and their family members because the systems were just too weak after the war. And there was a lot of mistrust from the war as well, but there was no reason to have trust in the medical system. There was reason to have trust in individual nurses and doctors, but the system didn't didn't work even before it was destroyed by Ebola. And back to those debates that we used to have, like how much are you going to invest in one person? You know, whenever someone says we're living in a time of limited resources, it's a rhetorical point, right? It's to mark a conversation like a dog marks a tree or something. If we're living in a time of limited resources, we should first say yes, but they're less limited now than ever before in human history. Right? We have more tools, more resources. Compare this to the big one in 1918. You know, so we shouldn't say that without real reflection on why we're saying it. You know, and my professorial and loving response to you around that case was probably similar. You know, why are we taking this patient for heart surgery? Well, because he showed up in our clinic or in our hospital dying. And this is if somewhere in the global political economy, this can be fixed, right? Let me just say one thing before turning it back to more questions. Never in my life have I seen a more robust conversation about the shortcomings of purely economic logic. Right? I see it unfolding in the most affluent, powerful nation in the world, or the two of them, right? Basically, the argument that's been sub rosa or couched in narrowly ethical terms, like some of our discussions from back in the day. Instead of that, we actually have a lot of people saying, well, what matters to us? Do we want grandma, you know, to be put at risk or die so that we can go back to work prematurely or something? This is a new thing for me to say. I've never seen this. And I think part of it is a very healthy discussion. Like what matters to us? And crises always offer the opportunity to make meaning.
I have many more questions, but let me open it up to folks who have been sending their questions over the internet.
Thanks, Deb, and thanks, Paul, for a fantastic talk. I'll start with a question about how do you see the effects of this complicating existing crises, both infectious like HIV and TB and non-infectious like poverty and malnutrition? Is it as simple as each makes the other worse, or is there some other insight you have on that?
Well, I don't have a lot of insight except through previous epidemics and previous pathologies. And I think it's like saying, you know, can we count on coronavirus going kind of dormant in the warmer months? Yeah, it might be seasonable, but let's not count on it, right? It might be that some pathology, a non-communicable pathology, some, you know, a heart disease or diabetes or God knows what, it might be that those people do better instead of worse than people without those comorbidities, but there's no reason to believe that's going to be the case. So with the rise of all of these non-communicable pathogens, which again, some of it was masked by the fact that in a lot of these clinical deserts, children die of vaccine preventable illnesses and adults die of malaria, AIDS, or tuberculosis. So when you get rid of that absurd and premature mortality by actually vaccinating children, providing pediatric care when they're sick, and making sure that adults have diagnosis and therapy for AIDS, tuberculosis, and malaria, when you do that, life expectancy goes up, and you reveal a lot of other pathogens. So to give the numbers from Rwanda, since they're the most stunning, even leaving aside the genocide in 1994, which pushed them back, of course, in the last 20 years, Rwanda has seen its life expectancy double. And the declines in mortality that have been described by multiple authors in multiple studies show, if you look at case fatality rate, among patients with HIV, TB, or malaria, say those declines have been the steepest documented by and large anywhere. And the overall decline in premature mortality, well, those curves are the steepest declines ever reported at any time and in any place, right? So you see the non-communicable pathogens, they pop out in front of you because people are living longer and better lives, actually. And I think that we're in for a big collision, you know, and again, I keep thinking of those, you know, people crammed together in refugee camps or crowded urban slums who can't, you know, who maybe they have diabetes or maybe they have hypertension, maybe they have asthma. A lot of people do. They can't really socially distance. So that's one of the collisions I'm looking for. My colleagues who have been working so hard on addressing non-communicable diseases and injuries in resource poor settings, like Gene Buchman at the Brigham and at Partners in Health, they are already making some of their resources available to the COVID response, and they have scant resources, but they see that this disease is likely to crash into the patients that they've been caring for who have non-communicable diseases.
Thank you so much for a wonderful talk, Paul. Another question we have is, touching back to what you said earlier about quote unquote special populations, such as refugees or prisoners who are kept in close quarters, what unique remedies are or perhaps should be available for these populations?
Well, you know, some of them are not unrelated to that rather philosophical flourish I just made. I've never seen, at least in the United States, I've never seen this kind of discussion, you know, about, well, what should our policy be response be? You know, it costs a lot to have no safety net. It costs a lot not to make it so hard to get unemployment insurance, or paid work leaves. I mean, telling everybody to go home and then what? Just as we are able to have a better and deeper conversation about these matters now, I think this is our chance to say, well, do we really want to have 2 million Americans in jail? Do we really want to not have alternatives to incarceration? Do we not want to address the refugee crisis seriously? I mean, if you have in Greece, you know, you have a camp designed for 3,000 refugees, and there are 20,000 refugees in it. I mean, how are they going to do social distancing in Greece? You know, and so I'm hoping, and I know this again sounds philosophical, that we get to have a chance to have this discussion. Is this the way to manage, for example, nonviolent offenders, or is this a way to manage a refugee crisis? The answers are no and no. And can we move forward more progressive, humane policies around prisons? In Haiti, you know, in Haiti, they're contemplating just closing the prisons because you take away someone's agency. There are not a lot of prisoners. I do want to say that. You take away someone's agency and then say shelter in place and no one's bringing food. I mean, we've been through this horror show already in other settings. And in Rwanda, they already did prison reform. Again, probably 15 years ago. And, you know, I just remember going into one prison not far from the hospital where I was working, where there are 11,000 prisoners in one prison. And there were no physicians, zero. One of our patients had been arrested, surely on genocide-related charges. That 70% of the people in that prison were there on genocide-related charges. And we followed him into the prison saying, hey, our patient's been arrested, can we see him? And the prison director said, yeah, could you see some other people too? And they had just begun this massive prison reform effort, which ended up clearing out that prison and all the others, and going from a total prison population of like 300,000 down to very low levels. And you know, again, that was a very socially brutal process of accountability, forgiveness, pardon, through a series of course, but there was no violence in the course of that prison reform, and people were reintegrated, with a few notorious exceptions, were reintegrated into Rwandan society.
Paul, I think that you and I have had the humbling experience of watching how many people are kind of rallying and stepping up and wanting to volunteer, you know, their time, their efforts, their expertises to trying to attack COVID-19. This is a somewhat research-oriented crowd, and so you've probably heard of, you know, efforts to do 3D printing of ventilators, you know, develop kind of the next generation rapid diagnostics. But what is your opinion on the impact that these type of efforts will have?
Well, you know, first of all, if we could get those creative research minds to hear us when we say, hey, you know, when you hand us a widget, someone still has to do the implementation, and that's really hard to do, right? So there's no law that says people who are designing 3D, using 3D printers to make mechanical ventilators, there's no law saying they can't actually work with the implementers to put these in place, assess them, evaluate them, et cetera. That delivery science is too low prestige at places like Harvard, MIT, the Broad. We should have more respect for that kind of implementation science, if we call it that. So that's one thing I would say. The other is, hey, we need your innovations. I mean, what are the things that we're all counting on now? And that is a vaccine. And that's a pretty scary position to be in, right? Is it going to take a year? Is it going to take 18 months to ramp up production to hundreds of millions of doses? I mean, you'd know more about that than I do, but I don't think, that in those months between now and when we have a vaccine that's ramped up, the losses are going to be too great. And that surge, again, not that many people have seen what a surge like that can look like. And when it takes out the healthcare delivery system, it's already too late in the sense of we can't count on a vaccine in the next few months. And it'd be great if we find a specific antiviral therapy that's really effective. And maybe even we'll find one that's effective without fluid resuscitation and oxygen. I have my doubts, and I'm sure you do too. So we really need to both welcome those innovations and research implications, but we need a little more help, I think, on the pragmatics of implementation and not just assuming, hey, here's your product. Let it be the magic bullet to save us all. Is that too grim, Deb?
No, it's not. I mean, we want to know what reality is with respect to what we're doing. But do you worry that if we're reacting in the moment to this acute event, there's talk about relaxing, regulations or, these kinds of things. Do you worry? I mean, regulations and rules are there for a reason.
Right? I'm worried. I mean, and part of it, again, is that I know people are sick of hearing us say this, we don't know. We don't know what's going to happen. I mean, I get that all day long, and you do too. What's going to happen? What's going to happen? So we don't know. I mean, it would be silly for us to pretend we don't have experience, that we don't understand any coronavirus, that we don't understand respiratory pathogens. That would be foolish and unwarranted. But we don't really know the specifics. Therefore, if you see the numbers going up in New York or New Orleans, the idea of relaxing restrictions, it seems so wrong-headed and so premature. And yet people living in precarity, they need incomes, So we either bite the bullet and do what's right in terms of social policy, which we can, and I hope we'll do, or we trigger something premature. And again, China's facing this now, I'm sure South Korea and other nation states, or we pull the trigger prematurely and see another wave of cases. I mean, it's very worrisome.
We're getting a question on social costs of epidemics. And I guess I'd ask how you have seen countries rebuild from things that decimate a population like you've seen, and what lessons can we take when it seems like much of the world might be going through an event like that?
Well, first of all, that's a great question, and one that, I think about a lot just by virtue of moving. I don't go from place to place like a consultant, but going back to the same places again and again over many years. So that's the way to see these changes up close and personal. So in Rwanda, I was very reluctant to confess this publicly, but I finally did in Rwanda after 15 years of working there and 10 years of living there, was that in 1994, I was an ID fellow at the time in the Longwood Medical Area Program. And I'd already been working in Haiti for over a decade. And things were tough in Haiti that year. There'd been a coup again. And I just remember reading about Rwanda and thinking, they're never going to get over this. They're never going to have this social healing, back to your question. And, and first of all, how would I know? I'd never set foot in Rwanda. So, but I fortunately didn't share those thoughts with others. The fact that they have managed to rebuild from that, again, not just the genocide, but the war, which led to material devastation of all kinds. The fact that they came back from that has permanently altered my view of what's possible. How they did, I mentioned a couple of things like the prison reform. The prison reform was actually a process of social reintegration, which drew on some traditional Rwandan ideas of how do you settle a dispute. And the list goes on, the forward-thinking policies, the erection and rollout of a publicly funded care delivery system, the advance for gender equity, meaning pushing for more women in leadership roles. I mean, Rwanda famously has more women parliamentarians than any country in the world. Just a whole series of things that happen, and many of them at the same time, that still merit study, right? We can still learn from Rwanda's recovery. And since that is such a dramatic example, I hope that we'll think about it as we're thinking about COVID. What I saw in West Africa in 2014 and 2015 also scars me. I mean, scars people in much more direct ways, but I'm saying seeing a healthcare system collapse because of a surge is a very scary prospect. Because there's no backup, right? You're in a big capital city like Monrovia or Freetown. If you need to be intubated, you're shit out of luck, right? You're not going to get the care that you need, especially if you don't have Ebola, right? So, and this is something that Deb and I have been discussing. So when you have a surge that causes the healthcare system to collapse, the real casualties are largely people without the problems that led to the collapse, meaning without Ebola, without coronavirus, without a war injury, whatever it was. There are people with obstructed labor, a bad case of malaria, pneumonia, need antibiotics. I mean, last week, 3 days ago, the senior advisor of our cancer program in Haiti is a Haitian physician who we've worked with, is very close to us. 3 days ago, she was carjacked and shot in the chest in a rural area, a couple hours, I think, from the main referral hospital. Imagine if a surge had closed that hospital. She got shot in the chest, she had a hemothorax. She had blood in her, where her lung should have been. And was dying, but she didn't die because the surge hasn't knocked out the hospital. The surgeons were on call. There was blood. There were plenty of people to take care of her. They were all her colleagues, of course. There were nurses on call. There's an ICU. So I'm trying to bring this back to, there's nothing worse than seeing a surge take out a healthcare system. And I don't wish that on anyone.
So Paul, I'm going to end with one last question. And I'm asking because I know you're not shy about these kinds of things. If you look around the world and what's been happening with COVID-19, who are the heroes? Who are the villains?
Well, I'm not shy about trying to answer. I know for the heroes, I'm going to go with the caregivers, particularly the nurses, because the nurses and nursing assistants do so much of the heavy lifting of caregiving, right? ICU care, I mean, like at the Brigham, I mean, who runs the vents, who makes sure the patients, have their hair combed, much less get suction. So I'm going to go with the nurses for the heroes. Of course, we got our favorite doctors out there, like Tony Fauci and Deb Birx, right? But the bulk of care will be given by family members and professional nurses. So they're my heroes. Villains, you know, it's the virus is the villain. You know, I know it's not and it's not a thing that, but I do think, you know, yeah, I'm really disappointed in a lot of the policy decisions being made. I'm really disappointed that, you know, we didn't turn with great urgency toward the preparation that we should have been able to have here in this country. Of course, I'm disappointed as an American, and we had resources to do a better job, and we have resources to do a better job still. But I think I don't want to be cheap, you know, because I knew that stuff, and I feel like we just got the COVID tests that we were looking for Haiti. They just arrived yesterday. That's too long too, you know. You know, I don't want to feel like a villain, and because of an inability to raise the alarm quickly enough or to get stuff that's difficult to shipped. So I think the virus is going to be my villain, along with weak health systems, and you know, as opposed to a person. So that, in other words, structural violence, the whole idea is because we all share responsibility, and the degree to which we share responsibility is related to how much influence and power we have. And I would not want to take cheap shots at other individuals, not because I'm reluctant, but because I'm mindful of our own shared responsibility.
Thank you, Paul. Thank you. I know you have such little free time, so I really appreciate your taking the time to do this and to speak to our community.
It's an honor, Deb, and I may be socially distanced from you by a few meters or whatever, but I'm with you, and thank you for what you're doing too.
All right, thank you. So to everyone, this talk will be available. It's been recorded and will be available at the same site. Thank you, Paul.
Thanks, Deb. Is it off?